Alrighty, welcome everybody on this beautiful Thursday afternoon. Spring is in the air, and that also means we may have some allergies in the air. I know some of you haven't been very busy with the sick visits, but we know with allergy season, that's not going to stop patients from needing some help. So we're here to introduce we're going to call it newest allergist, Dr. Sai Nimmagadda. Dr. Nimmagadda sees patients in our Grayslake facility and our brand new Skokie facility. And we're very excited that he has circled back here at Lurie Children's. And how about without any further ado, I'm going to hand it over to Dr. Nimmagadda, and he's going to talk a little bit about his journey back to Lurie Children's. And he's also going to discuss partnering with Allergy, how testing can help. So Dr. Nimmagadda, take it away.
Thank you, Chad. Thank you, guys. It's so odd to be talking to my computer and not being able to see you guys all face to face. I know that I've got a lot of old friends in the community and probably will develop some new friends over time. Many of you have known I've been in Chicago for almost 30 plus years now. I think I started my residency back in 1989 at Columbus Cabrini Medical Center that was affiliated with back in that day, it was called Children's Memorial Hospital. And then I went on to do a fellowship at Allergy at Denver, Colorado at National Jewish Medical Center. And then I came back and I joined Richard Evans, Jackie Pongrasic back in 1996. So back then it was just the three of us in the division. And at the time I was full-time faculty from 1996 until about 2001, and then from there I went part-time to about 2007. And then since then, I went to private practice in the Northwest suburbs, Highland Park, Hoffman Estates, and Lincoln Park. And now I've decided to come back to Lurie Children's Center and decided to join their division again with Dr. Pongrasic's blessing. She took me back, and I'm excited to be back here. My kids are all grown up now, so I've got a lot more time on my hands. I miss the teaching, I miss the residents, I miss the camaraderie of a large institution. I'm also doing a lot of allergy research with Dr. Arushi Gupta, and we got a couple of really exciting clinical studies coming out looking at early intervention therapies for food allergy and food allergy patients. So it's really strange being here in COVID. I'm in my office. I've been cooped up here for, I don't know, almost a year, literally talking to my computer, Zooming with everybody, and you guys are all doing the same thing as well. It's good to be able to get back into the clinical world and to start to see patients again at these clinical outreach centers. And like Chad said, I'm up in Grayslake on Mondays, I'm in Skokie on Tuesdays, and the rest of the time I'm doing research with CFAR, which is Center for Food Allergy, Asthma, and Allergy Research down at Northwestern. So I thought that what I would do is I would just break open with this first talk about partnering with Allergy and how testing can help, just to really go over the basic stuff that I do and try to reintroduce myself and our procedures and our clinical testing procedures and all. But I'd like to have an ongoing series over the next 6 months to a year, maybe once a quarter or maybe once every 4 months or so. I'd like to take up some topics that you guys all feel that you want to hear from me or the allergy team, and I would be more than happy to put together a talk or a discussion regarding any clinical questions you guys may have regarding infant feedings, to food allergy, to asthma management, to allergic rhinitis, to immunotherapy, to immune deficiency, and so forth. So there's a lot of different areas that I could touch upon for you all here in the Northwest suburbs and also all around Chicago. So if there's anything that you would like me to discuss, you can email Chad or email myself, and I'll get that on the books and get that all those dates arranged for. So
feel free to put it in the chat room too, folks, and we can take a look at that. Also, be sure to ask any questions you may have in the chat room too.
Thank you, Chad. Yes, absolutely. Put that in the chat room, and I promise we'll get to all the topics that we need to over the next year or so. So I'd like to have this to be an ongoing series. I think we'll have a lot of fun. I think we'll all grow and learn together. And there's so many interesting topics coming out there, especially with early introduction of foods and management of atopic dermatitis and the skin and so forth. So with that introduction, I'm back at Lurie. I'm excited to be back at what I call the big mothership, and it's fun. I've enjoyed interacting with the residents and the attendings. Dr. Pongrasic's been wonderful. The entire team at Lurie has been great. We've grown up, I think, to about 18 providers now, which is astonishing when it was just the three of us back in the late 1990s. So right now I don't have any disclosures. I'm basically employed physician at Lurie Children's Medical Center. So we thought we'd talk about partnering with allergy and the role of testing. And you know, a lot of what we do in allergy is both science and art. We sort of blend the science with the art of testing. Now everything isn't always, you know, accurate or 100%. If it was, I wish, you know, I wouldn't be here. I wouldn't probably be seeing patients. You can easily run off the immunocaps, or even there are some, you know, pediatricians that are doing skin testing in their clinics as well. But we thought we'd talk about, you know, a little bit about the advantages and the limitations of different allergy testing methods, and also discuss the key factors in interpreting these allergy tests. So a lot of times, you know, we talk about the patient with specific symptoms. Why is allergy diagnosis important? In kids with atopic dermatitis, I find that these children may have a lot of food triggers or even inhalant triggers to their disease process. Food allergy, of course, is almost the mainstay of what we do here in allergy. Almost 90% of what I currently practice now is associated with food allergy and food allergy determination, and also food challenges. Asthma, of course, it's very important to discuss the management and also specific triggers for asthma. Are the dust mites a concern in the home? Are there concerns with the new pet that the family just recently obtained? Especially with COVID, there's a lot of families that have adopted new pets nowadays, from cats to dogs to turtles to iguanas to fish and so forth. Allergic rhinitis, of course, you know, astonishingly, you know, a lot of our patients, they have allergic rhinitis, but we don't really identify their triggers and then to intensify their therapy during the season there. And of course, the adjustment with the allergy medications is really important. You can adjust the medications, but they don't really control symptoms. They only provide some intermittent benefit there if you don't take out the allergen specific triggers that a patient may have. And of course, allergen immunotherapy. Of all the things that we do, this is one thing that has never been funded by pharmaceutical research, but this allergen immunotherapy is the only disease modifying treatment that we have. And I've seen patients that have more moderate to severe asthma all of a sudden have mild disease or even no disease at all. So it's a modality that doesn't get used that frequently, but I really feel that we should start to see more patients that can be started on allergy immunotherapy, especially to help their asthma therapy. And of course, penicillin allergy. There's so many kids that I see in my clinics that come in with a history of penicillin allergy as an infant. They may have some dermatitis related features and so forth. So I think it's good to like de-label these kids over time. I think it's important to make sure that we're not overusing other antibiotics if they can be treated with amoxicillin or Augmentin or other first line or second line agents there. Allergic disease, why is it important? A lot of patients have it. About 40% of kids will have some form of allergic chronic illnesses, and also especially allergic rhinitis there. A lot of these cases develop, around 40% develop prior to the age of 6, and about 80% of them are going to develop before the age of 20. So pediatricians are the key gatekeepers in getting these kids tested and also evaluated to see what they're allergic to over time. The big 5 that I think that you're going to really start to partner with allergy here would be allergic rhinitis, allergic asthma, dermatitis, food allergy, and of course drug allergy that we see there. This algorithm looks complicated, but then again, it's not either. So the basic history, that of course is always key and it's always paramount. to make sure that there is a clinical history that results in clinical symptoms. So once you note that there's symptoms associated either with a food, if it's particularly milk exposure, or if there's a history of worsening asthma, or the child has increasing allergic rhinitis symptoms in the spring and summer months, we then hopefully you'd perform some additional diagnostic testing, depending upon what the clinical indication would be, either immunocap testing or referral to our clinics for specific IgE testing and also skin testing. So we would perform a test, and if the test is positive, we would confirm the IgE-mediated reaction. If it isn't, then of course, additional testing may be undertaken, and maybe even an oral food challenge, or at times even a challenge to the environmental triggers that the child may have. Total IgE, it only represents about less than 0.001% of all the immunoglobulins, but most of the IgE is bound to surface mast cells and basophils. So patients who do have reactivity, a lot of the IgE is already bound, and you're going to start to see clinical symptoms with any exposure that these kids may have. Allergy skin testing is our mainstay of testing, of course, and a lot of you have seen what we do and understand that it's a little bit like voodoo therapy. We put a little drop of water on the skin, we take a little needle or a device, a testing device, and we scratch the skin, and that's called percutaneous testing. We usually do this for up to about 25 to 30 different allergens. It can vary from seasonal pollens to perennial allergens such as house dust mites, mold, cat and dog, and also cockroach. Interestingly, here in the city of Chicago, mice and mouse allergen has also been detected in patients with severe asthma. So when it's performed correctly, it's actually reproducible. It demonstrates a good correlation with clinical symptoms, and they shouldn't always be used by itself, but with the proper history and clinical exposure, they can be confirmatory as far as testing goes. And again, the skin test devices, there's so many of them out there. They're plastic devices. We use the Dermapix. We also have the Lancets, and they all have different criteria. They can all sometimes create inflammation in the skin. So, to use these different testing devices, and they can vary from testing site to testing site. A lot of times, if a patient comes in with an allergy test results from a previous allergist or clinician, depending upon their symptoms or their signs that they have, or if they're not finding relief, or if the food in question is still in question, I may repeat the test at my own center just because of the variability that's out there with the skin tests within the community. Of course, there's a lot of variables that may affect skin testing. At times, we'll note the antihistamines. Sometimes, if I do not get a positive result, I really can't test the result. I really can't trust the other results. So it's very important that patients, when they come and see us, if we don't get that histamine to react, then we take a look at some of the medications if they've been on antihistamines, if they've had any steroids in the previous 2 weeks, and also whether or not the extract quality and things like that would be effective there. So without a positive skin test, I really can't trust the results of my testing that I did on the allergens that we have there. So the clinical sensitivity, especially with rhinitis and asthma, and this is why it's important, I think, to understand that even though we may test for the dog and the dog comes up positive in a child, or if the dog comes up negative in a child, it doesn't always 100% clinically correlate with the clinical symptoms there. So by having a family history of asthma or rhinitis, you may have some positive skin test reactivity, but no clinical disease or symptoms there. I think that's important, especially when the family has a new pet and they're wondering whether the child has increased symptoms associated with the pet. And now we're going to make a decision for the entire family whether or not to have some allergen control measures in place, or maybe even at times if symptoms are so severe that we'd have to recommend that the family remove the pet within the home. So again, we'll take a good history, we'll do a skin test, and if they do react, I may sometimes try some allergen control measures initially, and see how they do with that before recommending that they remove the pet there. Skin prick tests are good for food allergies, and the reason why I like them for food allergy diagnosis is because if a child is negative, it's 95% chance that they do not have a sensitivity to that food. If they're positive, it's only 50-50. Again, a lot of times, again, the art and the science of of knowing what to do and when to do it is also critical as well. A lot of times with the food, if the child is tolerating a food, I rarely will put on a skin test for that food. So if there's a question of a peanut and I know that the child has had an adequate dose, in other words, if they've had at least 2 grams before the age of 1, or at least 3 grams before the age of 3, and they're tolerating it, I generally don't want to even know what the skin test reactivity is. However, if they've never had the food, and you want to send them in for some screening, if they've got atopic dermatitis or if there's a concern for some potential related food allergy, then the negative test would be a little bit more of a useful tool for me than a positive test there. And again, the size of the skin prick test can then determine whether or not the likelihood of doing an oral challenge. And at times we can determine whether or not it's safe to clinically challenge these kids, especially the younger kids. So if they got a reactive milk skin prick test greater than 6 millimeters, I may end up challenging or less than 6 millimeters, I may end up challenging the child. If they're over 6 millimeters, I may not for the milk there. And more recently, and all the immunocaps have been coming into diagnostic testing here. The old RAST has been replaced in 1989 by what's been called by the pharmacia, or the CAP-RAST system, or the CAP-RAST immunocap that we call it there. They're really good. You can test a lot of different allergens. There's over 200 or so, anything from pollen to foods to penicillin to even to the venoms there. And again, if the child is tolerating the food, probably not to order that food allergy immunocap. It's better to order the ones where you're concerned with where they're not tolerating it, or if there's a specific reaction, or if there's a little bit of an indeterminate reaction, had a little bit of blotchiness around the face, had a little bit of fussiness, or maybe even a spit up or vomiting. Sometimes I've noted that some pediatricians will order immunocaps there. And again, determining the specific levels, again, there's a little bit of art to the science. And so again, we'll have to be clinically correlated with the child exposure there. So again, determining when to test, what to test, foods that are not often ingested are more likely triggers there. And the more common foods, of course, are going to be the tree nuts, the fish, the shellfish, the peanuts, milk, and egg. And those are the ones that we would want to try to order some immunocaps if there's any clinical questions there. And again, whenever I get the immunocaps, I usually follow it up with skin prick testing as well. So I think it's important that we have both tests in place before we make a clinical decision on the outcome of that specific allergen there. Kids with atopic dermatitis, a lot of these kids come in with positive skin tests, and whether or not the eczema is being flared by the atopic dermatitis or by the specific food, and whether atopic dermatitis is being flared by milk, wheat, or soy, it's tough to determine. A lot of times moms will remove the food in their diet, and they'll come to us and they say, well, I took out milk, or I stopped eating egg in my breast milk, and the kid's skin improved there. We will do some skin testing and also immunocaps to see where we're at with the levels of that allergen. And we may or may not proceed with an oral food challenge there. But again, with atopic dermatitis, a lot of these kids will have positive skin tests and also positive immunocaps as well. The specific IgE can be anywhere from 0 to over 100. Again, there's certain diagnostic criteria that we use that can show that that the curve will vary by the specific food, age, and also the specific assay there with that. A 0 doesn't always mean that there's a negative risk here. So I've had kids react even at 0 with milk, wheat, egg, and soy. So again, it is a test. It's not infallible, and there are some false negative results as well that we see there. But in general, if you see a child and they've had an egg exposure and they've had clinical symptoms, and you do an immunocap, and the child is over the age of 2 and is greater than 7, then it's mostly 95% predictive value for that specific allergen. And then with milk, of course, it'd be over 15. And with any tree nut or peanut, in general, if you've got a value of over 14, it's about 95% predictive value that the child has a food allergy to that specific food, and so forth there. Again, there's very few studies available that correlate clinical reaction to the tests. It's hard to vary. I've had kids anaphylax at really low levels, 2, 3, and 4, and 5. And I've had kids that have had mild highs when their levels are even higher than the clinical reactivity, 15 or even 20 or so. So again, the reactions can occur, and several studies do show that about 20% of patients with undetectable food can have a clinical reaction there. So again, partnering with allergy and determining which foods are safe to do that oral food challenge. We again may confirm it with a specialized allergy test, again doing the skin prick test and then performing an oral food challenge there. Cross-reactivity, there's a lot of cross-reactivity there, so I really recommend not ordering that screening panel of tree nuts or milk, wheat, and egg, because if it comes up positive, now you got to go back and redo the test, and then you got to determine which specific allergen you're going to order up there. Again, with oral food challenges, it's direct physician supervision. We'll try to determine when it's safe, when we have both clinical testing that we do both the skin as well as the immunocaps, if it's suggestive that they're sensitized, but then we'll do an oral challenge to see if they actually have a true allergy or if they're actually tolerant to the specific food there. Recently, more of the immunocaps have been looking at component diagnostic tests or component resolved diagnostics there, where they break the protein down into further components there. Many of you have seen us order the RH2 for the peanut component for the peanut allergic child. That's been shown to correlate well. If it's positive, that there's a greater chance of clinical reactivity to the peanut allergen. And again, with hazelnut and cashew, as well as walnut, pecan, almond, there's also component reflex diagnostics as well that can determine if there's cross-reactive proteins that's binding and making the test positive versus chance for a systemic reaction to be more specific immune-based reaction that we see there. Comparison, of course, skin testing it's highly sensitive, highly specific, it's reproducible, and it's easy to do, and it's really cost effective. It costs $6 to $9 per test, and other testing as far as the immunocaps can be anywhere from $50 per allergen up to $200 per allergen. So choose wisely with that there. A few points about penicillin allergy here. A lot of penicillin allergic kids sometimes receive broad spectrum antibiotics, tend to be a little bit more toxic, less effective, and also more costly there. 10% of patients reported penicillin allergy, but over 90% of these patients can actually tolerate penicillin. So we see a lot of kids that have had infant diagnosis of penicillin when they're 2, 3, 4 years of age. It's a delayed reaction. It gets on their chart. Majority of these kids have outgrown their penicillin allergy, and over 95% of them have a negative skin test. Sometimes when they get referred to us, I won't even do a skin test. I'll just go straight to the oral challenge or a two-dose challenge. We'll give them 5% or 10%, and then we'll give them a second dose of 90%, and we watch them in the clinic over a period of like 1 hour there. So any of the patients who have penicillin allergy, I think it's very important to get them delabeled over time. It can help direct future antibiotic therapies, and it always comes up with surgical procedures and things like that where we're called at the last minute to rule out a penicillin allergy there. Real briefly, in kids, I know spring's coming, so that means the bee season and wasp season is coming around the corner. Hopefully, it'll be warming up for us to be outside. Be also socially distant, of course. But in kids, most of the time, systemic reactions are only about 1% or so. But again, a lot of these kids, they don't outgrow their systemic reaction here, and I think it's important to get them tested. We can either do venom-specific IgE antibody tests or even skin testing here for a lot of these kids with insect sting allergy. And again, I think it's important to determine which kids will need testing. And again, referral for allergy evaluation for the sting allergy can determine whether or not testing is even needed, or if it was a large local reaction, or if it was an anaphylactic reaction associated with clinical symptoms there. So in summary, partnering with us, we can assist in confirming or excluding IgE sensitization. We can do a one-time consult where we can see the patient and see if they have any allergic rhinitis symptoms, and then co-manage them and or at least give you recommendations on what specific seasons you need to manage the kids instead of putting them on medicines throughout the year. We can do a more target-focused therapeutics there. We can also determine which foods would need to be orally challenged, and then also give us guidance in determining patients with atopic dermatitis to identify the foods that are triggering their sensitivities, or even their inhaled allergens there as well. And lastly, of course, penicillin, and then allergen immunotherapy if it's indicated in a patient who has a lot of seasonal allergies and you're continuing to use more and more allergy medications to control their reactions there. I'll stop it here. I got about 5 minutes left for any questions, and again, I really appreciate you taking time out of your day to come and hear me and get reintroduced and see what I look like. I still have my same mustache. My kids have been asking me to shave it off for about 10 years now, but I think it's a trademark, and I continue to wear it. Thanks again, Chad.
You're welcome. So thank you. This has been great. It's especially, like you said, going into the spring season. So I'm sure all of our attendees are very excited about this. And I could tell by some of the great questions we have. And so let me just go right into it. So Dr. Riley Minster, he writes, what's the youngest age you can order an ImmunoCap test and or skin test on?
It's a good question, Riley. Hello again. We haven't seen you in a while, but hopefully you're doing well up in the northwest suburbs of Libertyville. The LEAP guidelines, Riley, suggest that ImmunoCaps can be ordered even as low as 4 months of age. So if you've got a child with atopic dermatitis with a learning early about peanut exposure, the LEAP study, if you've got a child with a high risk potential with atopic dermatitis, which is mild to moderate, you can order ImmunoCaps as young as 4 months of age to guide you in whether or not safe introduction of a peanut allergen can be undertaken there. IgE will be lower in the infant groups, but you can order ImmunoCaps all the way from birth onwards. So there are measurable IgE, and we're starting to see that even in these high-risk kids with atopic dermatitis, if they have measurable IgE greater than 0.1 or at times greater than 0.35, if they're even measurable, suggest cautious introduction with peanuts or any other allergen that you may be doing. But you can order ImmunoCaps all the way from birth onwards.
It's great. Questions are flying in here, so I'm just going to roll. There's a few that are just kind of transitioning into the last one. So we are going to ask from Dr. Rolak, since you do both skin and ImmunoCap testing, is there a value in PCP ImmunoCap is there a value of doing PCP ImmunoCap in their office?
I wouldn't believe that there is. I think that doing ImmunoCaps, but then also understanding the different nuances with the ImmunoCaps. I would think that once you learn or understand the labs, because there are different labs with different variabilities. Again, if you get a zero reactive component there, would you send a kid home for a peanut test, or would you do a graded challenge, and so forth? So there are times when a negative test about 20% of the time could lead to a reaction. But then again, if it's a screen out and you do an immunocap in your office and the peanut comes back really high or over 14, then you can say with 95% certainty the child's has a peanut allergy or a food allergy. So a high result over the 95th predictive value would be useful, but anything in between, you're almost stuck with a referral and or allergy skin testing, and then potentially challenges down the road for that child.
Okay. So Dr. Puri asked, is there a specific age to do penicillin allergy testing?
There really isn't. Actually, we've seen 4 and 5-year-old kids have infant reactions at 6 to 8 months of age with a very non-clinical or nondescript type of a rash. So there really is not a real specific age where I would say send them in. I think the earlier that we can confirm that they don't have the allergy or that they've outgrown it or never existed, I think would be very useful for your patients, as well as prescribing antibiotics going forward. So anytime that you suspect a penicillin allergy, whether it's delayed or it's immediate, can be tested and then challenged to see if it actually does exist.
Okay. So Dr. Jeff Rolick asked another question. At what age is it reasonable to try a PCN again in a PCN labeled child?
In a penicillin allergic child and a peanut allergic child, I think that's what we're talking about, those two abbreviations there. So penicillin allergic child, I would say that, within 3 to 5 years after, well, let me clarify. If it's a delayed type of a skin reaction there, I think you can probably safely do a 1-dose or even a 2-dose oral challenge, where you bring them into the clinic and then do a 2-dose challenge. But if it's an IgE-mediated reaction, if there's clinical hives, if there's clinical urticaria, if it's more of an immediate type of reaction, then I would say that sending them in for skin testing and as well as an oral challenge would be probably the safest route for that patient there. Regarding the peanut, again, it would be based upon clinical reactivity, taking a look at the immunocaps and the direction that they're going. If they remain high, then I would say that you probably shouldn't re-challenge that child. But if they're starting to decline and the skin test is also declining, then that may be a child that would benefit from an oral challenge.
Okay. With the subject of testing, and you kind of touched on this on another question, but Julie Kochbrenner, she asked a good question. How much of this testing can be done in a primary care environment? Is it most efficient to have an allergist involved in this testing?
Yeah, it depends. I've seen some pediatricians try to undertake some of the testing, but again, there's so many nuances with that. You have to make sure that the extracts are fresh. You got to make sure that your positive and negative control are accurate, and you also have to know that the variability of the skin test that may arise. So there is a little bit of art in the science of the testing there. So can it be done? It can, but then again, keeping up with the education of it, keeping up with the extracts, keeping up with the nuances of the testing, and so forth there. And again, with the foods, you get a 50% positive, or I would say 50% of the foods that you test may be positive, but are clinically tolerated for the child. So again, screening out which tests to do, when to do them, and how to do them. So there is a little bit of a learning curve for the primary care to undertake this, but it can be done.
Okay. Well, I'm going through the questions here in the chat room, and I think that covers the questions that are added so far. So I'd like to ask you. You touched on you are seeing patients out of Grayslake and out of Skokie. Can you let us know what days a week that you're at each location?
Yes, that's a good question. I'm up in Grayslake every Monday, and I'm in Skokie every Tuesday. We plan to maybe add a few Saturday clinics and also some clinics throughout the week as well, maybe on a Thursday if there's clinical space. So intermittently, but consistently, Mondays in Grayslake, Tuesdays in Skokie, then potentially all other days, depending upon clinical availability.
Mm-hmm. And I'm going to share this information with everybody in the follow-up email, but why don't you let us know some of the best ways to get a hold of you?
Best ways to get a hold of me would be through my Lurie Children's email. So it's Nimmagadda, S and then Nimmagadda @luriechildrens.org. It's a good way to get a hold of me there. That goes right to my email there. And I think that I'm pretty responsive with that process there. You can always call the allergy division as well, and you can get a hold of me through the division of allergy if there's a clinical question that needs to be asked right away. If you email me, I can usually call you guys back up, or even give you my cell phone for more personal contact for the future as well. So I hate to give it out directly right now, but if you email me, I'd be more than happy to share my cell phone number with you, and we can text back and forth as needed.
That'd be great. And there's Lurie MD is also available for all of you, and Epic for those of you, or a direct message. So those are all available for most of you as well. So, and then for those of you who joined late and don't know who I am, I'm Chad Worley. I am your physician liaison for the north of the city, north and northwest suburbs. So I am here for you for questions, and you should all have my email address and my phone number, but you'll get that in the follow-up email as well. But I just like to take this moment to thank everybody for joining us today. You'll be receiving this recording in an email later. I encourage you to share it with your colleagues, as Dr. Nimmagadda shared some great information with us today. And again, thank you for joining us. And Dr. Nimmagadda, would you like to say anything before we leave?
No, again, thank you all for taking time out of your day, and please, comment in the about what talks that you'd like in the future, and I'll put together, a series over the next 6 months to a year, and maybe we can touch on a lot of stuff that you guys want to hear about. Thank you again.
That'd be great. All right, everybody. Well, enjoy this beautiful day, and thank you for joining us on your lunch hour, and be well.